Welcome to the Radiographics Podcast. I'm Wendy Gibbs, and I'm joined by my co-host Ross Frederick. This week we have two more interesting papers to summarize. Mine is a fascinating review of the science behind and imaging features of CAR T therapy and complications. You know I love discussing these new advances in oncology. The better we understand the treatment, the more valuable we can be to helping these patients. And it's just really cool, so fun to learn about. Then Dr. Frederick will talk about central nervous system lupus, which interestingly is becoming more prevalent. We know more about this disease now, and earlier diagnosis has improved survival, but there's still significant mortality, so it's important to know. Okay, let's start with CAR T. Treatment of hematologic malignancies has undergone major advances in the past 2 decades, with development of monoclonal antibodies, antibody-drug conjugates, new targeted therapies, and immune checkpoint inhibitors. The most recent innovation in our armamentarium is chimeric antigen receptor T-cell therapy, or CAR T, a breakthrough treatment now frequently used for recurrent or refractory B-cell lymphomas, B-cell acute lymphoblastic leukemia, and most recently, multiple myeloma. An understanding of the basic principles of CAR T-cell therapy and knowledge of the expected imaging manifestations of treatment response and unique associated complications is important for all radiologists in order to accurately interpret their studies and provide optimal care. CAR T-cell therapy is a type of cellular immunotherapy, or adoptive cell therapy, that utilizes artificially enhanced T-cells to enhance the eradication of malignancy through activation and enhancement of the native immune system. Traditional adoptive T-cell therapy includes allogeneic hematopoietic cell transplantation and donor lymphocyte infusion, which have significant morbidity and mortality. For this reason, other adoptive cell therapies have been developed to be more tumor-specific and decrease off-target cytotoxicity. These include tumor-infiltrating lymphocyte, or TIL therapy, which harvests killer T-cells that have infiltrated a tumor, then activates and amplifies them before reinfusion into the patient. Engineered T-cell receptor therapy, TCR, can be helpful when native T-cells do not recognize the tumor and cannot be sufficiently activated or multiplied. TCR therapy extracts T-cells and equips them with engineered T-cell receptors targeting recognized tumor antigens before expansion and reinfusion. However, TIL and TCR therapies can target only tumor antigens that have been processed and presented as foreign cell antigens by major histocompatibility complex, or MHC, class glycoproteins, if you remember your immunology. Not all cancer cells express the antigen MHC complex, allowing subsets of tumor cells to escape the T-cell immune response. Chimeric antigen receptor T-cells, CAR T, have been created to address this problem. The first FDA approval for CAR T-cells was granted in 2017 because of the results of the global Phase 2 Eliana trial, which documented complete remission in 82% of enrolled patients with B-cell ALL. CAR Ts are laboratory-constructed functional cell receptor mechanisms that are transfected, remember that, usually via a viral vector, onto a patient's previously harvested native T-cells, allowing the bioengineered CAR T-cell to bind to a tumor-associated antigen, even if that antigen is not presented by the MHC. This permits an immune-mediated attack on the naturally expressed antigens of tumor cells. One advantage of this type of therapy is the ability to target and eliminate a larger proportion of cancer cells with naturally expressed antigens. The steps involved in CAR T-cell therapy start with apheresis of the patient and isolation and enrichment of T-cell populations. The cryopreserved blood products are sent to a laboratory where ex vivo creation of CAR T-cells is achieved through viral or non-viral genetic modification of the T-cell with transfection of the CAR. Expansion of the CAR T-cell population is then performed in a bioreactor before quality testing and shipping the CAR T-cell product back to the hospital for transfusion into the patient. The process logistics have improved over time, and the process now takes less than 7 days for turnaround. In the interim, the patient undergoes 3 days of conditioning chemotherapy to optimize the environment for the CAR T cells by destroying myeloid suppressor and regulatory T cells in the circulation. Reinfusion of the CAR T cells then takes place, leading to volume expansion and increase of the CAR T cell population in vivo and subsequent treatment effect on the tumor. CAR T-cell therapy is now the standard of care for aggressive, recurrent, or refractory non-Hodgkin's lymphoma, including diffuse large B-cell lymphoma, primary mediastinal B-cell lymphoma, high-grade B-cell lymphoma, transformed follicular lymphoma, and mantle cell lymphoma, and for recurrent or refractory ALL in patients under 25 years old. FDA approval was granted in March 2021 for the first CAR product targeting recurrent or refractory multiple myeloma. Advantages include a single treatment episode of 2 to 3 weeks and durable disease elimination, with remission rates of over 80%. That's pretty incredible. CAR T cells have demonstrated effectiveness in persistently refractory cases, including in patients with prior failed stem cell transplants. CAR T cell treatment efficacy may endure owing to self-renewing memory CAR T cells that can continue to replicate and circulate. This effect has been referred to as a living drug, and it's theorized that efficacy may potentially last for decades. CT and PET-CT are the imaging modalities used for evaluation of tumor response. Typical imaging response patterns after CAR T-cell therapy are a decrease in lesion size on anatomic imaging, a decrease in FDG uptake on PET, or both, usually within 1 month in responders. Chest radiography is often used to assess the patient's condition in the days after infusion of the CAR T cells, and may be the first imaging modality to allow identification of treatment complications. Local parenchymal changes can occur owing to T-cell infiltration of the tumor and may be misinterpreted as superinfection, so we have to watch out for that. Positive responses in CAR T-cell therapy are more rapid than conventional therapy. Some cases have demonstrated response at PET-CT within 1 month after treatment. Knowledge of the CAR T-cell biology timeline aids in imaging interpretation. Local in vivo amplification of CAR T-cells occurs within the first 3 days after infusion, causing local tumor swelling from edema and infiltration by the CAR T-cells. As the CAR T-cell population expands within the peripheral blood pool, peaking at about day 10 after infusion, simultaneous release of cytokines, including interleukin-6, cause an increase in systemic inflammatory response. There's rapid tumor regression in responders within the first 3 to 10 days after therapy initiation. After day 10, CAR T cells increasingly redistribute to the bone marrow and continue to replicate. Immunosuppression with infection risk is increased for the first 3 days after the CAR T cell infusion, primarily from neutropenia due to the initial conditioning chemotherapy. Agranulocytosis occurs between day 3 and day 10, followed by gradual bone marrow recovery. Nevertheless, there may be long-term lymphopenia and hypogammaglobulinemia. CAR T cells can persist in the peripheral blood for over 1 year, and potentially much longer. Common adverse events after CAR T cell therapy are cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome. Others include tumor lysis syndrome, transfusion reactions, and infection. Cytokine release syndrome, which I'll now call CRS, is the most common immune therapy toxic effect related to CAR T-cell administration. Post-treatment CRS affects most patients with ALL and lymphoma receiving it. It predominantly ensues from T-cell activation and stimulation, leading to a hyperimmune systemic inflammatory response, including release of cytokines and chemokines, causing marked cell aggregation and further increasing the levels of inflammatory molecules. CRS affects multiple organ systems. Inflammation and injury of the vascular endothelium lead to loss of integrity, capillary leak, disseminated intravascular coagulation, and hemodynamic instability. Coagulopathy after CAR T-cell therapy is reported in up to 1/2 of patients. Respiratory symptoms are very common. Acute lung injury can manifest as pneumonitis or adult respiratory distress syndrome. Imaging mimics of CRS include transfusion-related acute lung injury, or TRALI. An accurate and detailed clinical history is crucial to arriving at the correct diagnosis. TRALI is a life-threatening hypersensitivity reaction to intravenous transfusion of plasma-containing blood products and is specifically linked to the presence of anti-leukocyte antibodies in the transfusion. From a temporal perspective, TRALI occurs during or within 6 hours of a blood transfusion. Chest radiography will demonstrate a non-cardiogenic edema pattern including increased interstitial markings without cardiomegaly or pleural effusion. Immune effector cell-associated neurotoxicity syndrome, also called ICANS, is the second most common adverse event. The prevalence is 23 to 67% in patients with lymphoma and 40 to 60% in patients with leukemia, very common. The onset of ICANS is generally 4 days after CAR T-cell infusion, with a peak at 7 days. Resolution is expected by 21 to 54 days, although a small minority of patients may have longer-term complications. Characteristic MRI findings are usually seen in patients with moderate to severe ICANS and can include symmetric T2-weighted or FLAIR hyperintensities in the periventricular or subcortical white matter, and occasional external and extreme capsule involvement. There can be reversible hyperintense T2-weighted or FLAIR signal and edema in the thalami, pons, and medulla. Diffuse cerebral edema with swelling of the thalami may be present in severe cases. Less common MRI findings include acute intracranial hemorrhage with or without mass effect and cortical diffusion restriction, preferentially affecting the watershed areas, similar to posterior reversible encephalopathy syndrome, PRES. How about tumor lysis syndrome? This is a serious, life-threatening complication caused by rapid tumor breakdown after therapy. Deposition of tumor intracellular contents into the blood circulation causes metabolic abnormalities, leading to fever, cardiac arrhythmias, acute kidney injury, and seizures. It's particularly associated with proliferative tumors such as high-grade NHL and ALL. Tumor lysis syndrome occurs 0 to 4 days after therapy initiation. The imaging appearance of TLS can imitate that of CRS, with bilateral diffuse lung opacities on chest radiographs and CT. TLS and CRS can be present concurrently, further confounding the radiologic and clinical picture. The final adverse event discussed is immune system suppression and infection. The original malignancy, multiple prior chemotherapy regimens, and relapsed or refractory disease, and prior stem cell transplant all contribute to pre-therapy immunodeficiency. Further immunosuppression specific to CAR T-cell therapy arises from deliberate lymphodepletion before CAR T-cell infusion, leading to cytopenia and protracted cellular immunodeficiency. CAR T-cell recipients remain susceptible to infectious illnesses for a long time, and early and late post-therapy infections are common. Bacterial illnesses are the most common and earliest infectious complication after CAR T-cell therapy, occurring in almost 1/5 of patients with median occurrence at day 18. The infection may be hematologic or localized. On imaging, bacterial pneumonia commonly manifests as lobar or sublobar consolidation, often abutting the lateral pleura. It may also appear as multiple pulmonary nodules or patchy peribronchial opacities, depending on the organism. Viral infection, usually of the respiratory tract, is the second most common post-therapy infectious complication, with a median time frame of 48 days. Imaging manifestations of viral infection include patchy lung opacities, ground glass attenuation, small centrilobular and tree and bud nodules less than 10 millimeters in diameter, and thickening of the interlobular septa or bronchial walls. Fungal pulmonary infection in immunosuppressed patients may manifest as sublobar consolidation or multifocal lung masses with irregular margins with or without ground glass halos. Okay, that's a lot. I'll stop there. A lot of interesting information and good information about the brain and lung findings we might see in these patients after treatment. Thoracic imaging represents a critical tool in assessment of patients who develop clinical features concerning for CRS, such as fever, respiratory failure, and hemodynamic instability. Look for those ground glass opacities, pleural effusions, pulmonary edema, and atelectasis. And brain MRI plays a vital role in assessing ICANS, with vasogenic edema in the white matter, thalami, and basal ganglia. Now let's switch gears and learn more about the central nervous system features of lupus.
Central nervous system systemic lupus erythematosus, pathophysiologic, clinical, and imaging features. Systemic lupus erythematosus, also known as SLE, is a systemic autoimmune disease characterized by multiple immunologic abnormalities and has the potential to involve the central nervous system. The prevalence of SLE seems to be growing, possibly because of earlier diagnosis and improved survival. However, the associated mortality is still high. This article focuses on neuropsychiatric SLE, which is caused by SLE-related CNS involvement and comprises a broad range of neurologic and psychiatric manifestations. Most commonly affected are young females. The pathogenesis of neuropsychiatric SLE is multifactorial and can involve various inflammatory cytokines, antibodies, and immune complexes, causing vasculopathic, cytotoxic, and autoantibody-mediated neuronal damage. The pathogenic mechanisms in neuropsychiatric SLE include ischemic processes and autoimmune processes. Ischemia is mainly related to thromboembolic events and are associated with vasculitis, non-inflammatory vasculopathy, and antiphospholipid syndrome. Ischemic processes result in focal forms of neuropsychiatric SLE. Autoimmune inflammatory processes tend to result in diffuse forms of neuropsychiatric SLE. Neuroimaging can be used to non-invasively identify CNS involvement in SLE. Compared with CT, MRI is a more sensitive imaging modality for detecting intracranial abnormalities and assessing the chronicity and evolution of these abnormalities. However, MRI only depicts abnormalities in about 75% of patients with neuropsychiatric SLE. MRI offers the advantage of avoiding radiation exposure. CT is particularly useful in detecting intracranial calcifications, which can be seen in SLE. When conventional MRI findings are negative, advanced neuroimaging such as SPECT, PET-CT, MR spectroscopy, perfusion-weighted MRI, or diffusion tensor imaging can be performed. SLE vasculopathy predominantly affects arterioles and capillaries, resulting in vessel tortuosity, vascular hyalinization, endothelial proliferation, and perivascular inflammation or gliosis. True cerebrovasculitis is considered to be rare. Neuropsychiatric SLE-related vasculitis and vasculopathy can also affect medium and small vessels and consequently result in chronic microvascular ischemic changes, lacunar infarcts, brain atrophy, large infarcts, intraparenchymal hemorrhage, microhemorrhage, or subarachnoid hemorrhage. In the setting of vasculitis and vasculopathy, MRI reveals areas of increased T2 flare intensity in the cerebral white matter, mainly distributed in the subcortical deep and periventricular regions. The brainstem and basal ganglia can also be involved. Lacunar infarcts are observed in 15% of patients with neuropsychiatric SLE. On MRI, these lesions appear as T1 hypointense and T2 flare hyperintense foci. Diffuse and regional brain atrophy is seen in up to 2/3 of patients with SLE. Brain atrophy manifests as loss of gray and white matter volume with compensatory generalized enlargement of subarachnoid spaces and widened sulci. Large infarct is one of the most debilitating complications of neuropsychiatric SLE and is found in 10 to 15% of patients at a mean age of 35 to 40 years. At MRI, acute large infarcts are territorially distributed on the basis of the major responsible arteries and are associated with restricted diffusion. At CT, loss of gray matter-white matter differentiation and the hyperdense vessel sign are well-known findings of acute infarct, although they are not sensitive. The prevalence of microhemorrhage in neuropsychiatric SLE is about 15%. Conventional MRI and CT often do not depict microhemorrhage. Susceptibility-weighted MRI and T2 star-weighted GRE MRI are sensitive for detecting microhemorrhage. The incidence of subarachnoid hemorrhage has been estimated to be almost 5 times higher in patients with SLE than in the general population, with a higher mortality and earlier onset. Major risk factors for subarachnoid hemorrhage and neuropsychiatric SLE are older patient age, higher steroid use, and history of blood transfusions. Antiphospholipid syndrome is characterized by arterial or venous thrombosis and the presence of elevated antiphospholipid antibodies. Large territorial infarcts, lacunar infarcts, localized territory cortical infarcts, bilateral border zone infarcts, anterior basal ganglia lesions, and stenotic arterial lesions are particularly common MRI findings in antiphospholipid syndrome. Demyelinating syndrome is seen in up to 3% of patients with neuropsychiatric SLE. The proposed mechanism is an autoimmune process with antibodies such as anti-aquaporin 4 antibodies penetrating neuroimmune interfaces including the blood-brain barrier and blood-CSF barrier. Anti-aquaporin 4 antibodies are implicated in neuromyelitis optica. Involvement of the optic nerve or chiasm can be seen in neuropsychiatric SLE, typically as a later manifestation. The visual outcome in SLE-associated optic neuritis is reported to be poor, even after steroid treatment. Acute optic neuritis is typically observed as bilateral T2 hyperintense, swollen, enhancing optic nerves that are most evident on coronal T2 weighted and contrast-enhanced T1 weighted FAT-SAT MRI. Diffusion or segmental bilateral optic nerve and or chiasmal involvement can be seen, although the optic nerve head is typically spared. In terms of mimics and pitfalls, multiple sclerosis can also be associated with optic neuritis and demonstrate similar T2 hyperintensity and enhancement in the optic nerves. However, in contrast to SLE-related NMO, bilateral optic nerve involvement and extension into the chiasm are rarely seen in multiple sclerosis. The white matter lesions of demyelinating syndrome in neuropsychiatric SLE are mainly distributed where aquaporin 4 is expressed, particularly in the periependymal regions, such as the periventricular white matter, corpus callosum, hypothalamus, medial thalamus, periaqueductal gray matter, and dorsal pons and medulla, including the area postrema. White matter lesions appear patchy and confluent, and enhancement or diffusion-weighted imaging hyperintensity can be seen in the acute phase. In terms of mimics and pitfalls, demyelinating white matter lesions in SLE may appear similar to multiple sclerosis lesions. However, periaqueductal brainstem and medullary lesions are more specific to NMO than to multiple sclerosis. Spinal cord lesions are usually longitudinally extensive. In SLE-related NMO, 3 or more vertebral levels of the spinal cord are typically involved, usually at the higher thoracic levels. Cord lesions can demonstrate associated edema and enhancement. Now let's discuss some SLE-related CNS complications. Posterior reversible encephalopathy syndrome, also known as PRES, has been described in 1–2% of patients with SLE, generally in association with SLE-related hypertension, antiphospholipid antibody positivity, or renal failure. On MRI, diffuse reversible T2 and flare hyperintensities are seen in the posterior circulation distribution, including the bilateral thalami, white matter of parietal and occipital lobes, and the brainstem. PRES is typically associated with mass effect. Restricted diffusion and or enhancement is seen in about 20% of cases. Progressive multifocal leukoencephalopathy, or PML, is a very rare complication in patients who have neuropsychiatric SLE. It is a serious, potentially fatal progressive infectious disease that results from reactivation of the JC virus during periods of immunosuppression, with consequent inflammation of oligodendrocytes. Patients with SLE who require immunosuppressive medications are at increased risk for PML. On MRI, PML lesions appear as multifocal, asymmetric, confluent T2 flare hyperintense white matter lesions in the subcortical parietal, occipital, and frontal lobes. Lesions involve the arcuate fibers, typically without enhancement. PML is often associated with volume loss. Lymphoproliferative disorders, including primary CNS lymphoma, are well-known complications of systemic immunosuppression. Approximately 95% of primary CNS lymphomas are diffuse large B-cell lymphomas. In immunocompetent patients, primary CNS lymphomas are typically seen as hyperattenuating enhancing lesions on CT images and as T2 hypointense homogeneously enhancing lesions that restrict diffusion on MRI. However, in immunocompromised patients such as those with SLE, primary CNS lymphomas can be seen as homogeneously, heterogeneously, or sometimes peripherally enhancing lesions with mass effect and variable diffusion restriction. So, to sum things up, lupus can look like anything in the brain. So when you're interpreting a scan in a patient with lupus, as with all things in life, it's best to keep an open mind.
Wow, okay. We will keep an open mind. Lupus can look like anything. That's it for this week's summaries. Take a look at these articles on the website or in the print journal, and look for all the additional related information on the website. And join us back in 2 weeks for more summaries.